Greetings, ladies and gentlemen. I'm sorry that I cannot be with you in person today, but I appreciate the opportunity to make this presentation to you. As you can see from the first slide, I'm going to speak to you about emerging and re-emerging infectious diseases in the context of there being a perpetual challenge, considering what we have been going through over the last several years. In order to set the stage, let's take a look at the causes of total deaths globally in the last recorded year of 2023. There have been an estimated 60 million deaths, 17% of which, or 10.3 million deaths, were due to infectious diseases. However, these are not evenly distributed throughout the world. As shown by this color-coded slide, the burden of infectious disease varies greatly by region, with the global south suffering disproportionately from infectious diseases, particularly in the areas of sub-Saharan Africa. Regarding our discussion today, I'm going to talk about global health and infectious diseases, but before I do, I want to contrast them with established and endemic infectious diseases, as well as spend a moment or two discussing the difference between eradicated and eliminated infectious diseases. So let's start off very briefly looking at what we refer to when we say a disease, an infectious disease, is established or endemic. The definition for this is that a disease that is prevalent for a sufficient period of time to allow for a relatively stable and predictable annual level of morbidity and mortality. And as you can see on the infections listed on this slide, lower respiratory infections take the lead with 2.5 million estimated deaths in the recorded year of 2023. Then there are diarrheal diseases, hepatitis, tuberculosis, HIV/AIDS, malaria, etc. I want to point out that some established infectious diseases at one time were really emerging infectious diseases, such as HIV/AIDS, which we first became aware of in 1981. But we have had it now for over 40 years, and it is now in the established stage where you can predict to a greater or lesser degree what the level of morbidity and mortality is globally. Moving on to just a brief discussion of the difference between eradicated and eliminated infectious diseases, many people don't fully appreciate, but there is only one human disease that has been truly eradicated from the globe, and that is smallpox, which was declared eradicated in 1980 due to a vaccination program. Parenthetically, there's one animal virus, rinderpest, or cattle plague, which was actually declared eliminated in 2011. So again, just for the purpose of definition, the eradication of a disease is a global and permanent achievement, while the elimination relates to its absence in a specific geographic area. In other words, eradication means that you no longer need an intervention because the disease is no longer present in nature. Whereas elimination is when deliberate efforts lead to local infections being reduced to zero within a defined geographic area. Now, a disease can be eliminated from one region without being eradicated globally, and we have many examples of that. The reason I bring this up is because actions to prevent the disease from transmitting or reemerging are still required once a disease is eliminated. And I'm going to mention in a moment, measles is such a good example of that. If you look in the United States, where I live, there are a number of diseases that have been eliminated. In other words, major threats are no longer seen nor found. And we find that with cholera, diphtheria, malaria, measles, polio, rubella, and yellow fever. However, as I mentioned just a moment ago, eliminated diseases can resurge. And historically in the United States, and we've seen this throughout the world, the United States is no exception. It's just an example. In 1989, to 1991, there was a widespread measles transmission in the United States. There were over 55,000 cases and at least 166 measles-related deaths. Almost all were in unimmunized children and about 25% in babies younger than 15 months. The cause was a budget cut in vaccination program during the Reagan administration, which led to low immunization rates, followed by vaccine hesitancy among some parents. Fast forward to today, and measles in the United States in 2025, we are having a resurgence due to the anti-vax attitude that we are now seeing growing in the United States. Just this year, we've seen over 1,600 reported cases in 42 of our 50 states, with 3 confirmed deaths. And as expected, the overwhelming majority have been in individuals who were either unvaccinated or their vaccination status was not known. 12% of the cases were hospitalized. Now compare that to the prior year of 2024, where in the entire year, there were only 285 cases. Now, with that as a background, let's take a look at what we're doing with the current discussion of emerging and re-emerging infectious diseases. Again, getting back to some fundamental definitions. An emerging infection is one that has been recognized in people for the first time. Classic examples of that is HIV/AIDS, SARS, COVID-19. Now, a disease may have existed for some time, but the etiologic agent is newly recognized. That constitutes an emerging infectious disease. A re-emerging infectious disease, and I will give you examples of this shortly, have existed in the past, but have reappeared, either in a different geographic location, in a resistant form, or even after a deliberate release, like we saw with the anthrax attacks in the United States in 2001. So going back over history, there are so many examples of a major infectious diseases that have emerged throughout history. I don't have time to go over each and every one of these, but I'm sure you recognize them from 4th to 5th century BC, the plague of Athens. Then there was the Black Death, or the pneumonic and bubonic plague of Yersinia pestis in the 14th century. And you go down through the years. Of note, if you look at the last 3 diseases on this slide, and I'll blow it up on the next slide shown here, is that 3 of the deadliest pandemics in human history have occurred in the past approximately 100 years. The influenza pandemic of 1918, in which 50 to 100 million people died in a world with a population only 1/3 of what it is today. So you can imagine what those numbers would be in a population that's much larger. Then there was HIV/AIDS, which we first recognized in 1981, with more than 44 million deaths, and COVID-19, familiar to all of us, which we first recognized at the end of 2019, early 2020, in which there have been 7 to 35 and probably an average of 20 million deaths globally. It is important to point out that around 75 to 80% of emerging pathogens are zoonotic. In other words, they have an animal reservoir that jumps species to the human. We've seen that with HIV from chimps to human, with the original MERS-CoV from bats to a civet cat, to a bat to a camel. We've seen it with Nipah, mostly in bats. We've seen it with influenza, which is mostly a bird virus, which has now accommodated itself to the human species. Again, around 75 to 80% of emerging infections are jumping species from a zoonotic source. Now, I certainly don't have time to address each and every one of the emerging infections on this slide, but I'm going to pick out a selected few to give you some prototypic examples. As I mentioned earlier, let's start with HIV. The first report of HIV, before we even knew it was HIV, was in June of 1981, pneumocystis in 5 young, gay, previously healthy men in Los Angeles. I might say personally, I did not have an appreciation of where this would go at the time until 1 month later, in July of 1981, when another report from the CDC showed not only 5, but now 26 young, previously healthy gay men, not only from Los Angeles, but from New York City and San Francisco, presenting with a pneumocystis pneumonia, but also multiple other opportunistic infections together with Kaposi sarcoma. The era of HIV/AIDS, even though we didn't fully appreciate, had begun and recognized in the summer of 1981. Fast forward and look at the global impact of HIV. 40 million people living with HIV at the end of last year. 1.3 million people newly infected in a year. 630,000 deaths in a year, and a cumulative death of 44 million people. Again, getting back to the origin, a zoonotic origin clearly documented that the primary reservoir for HIV, and has been the source of at least 3 independent introductions, is the chimpanzee. Going back to my own personal experience, back in the early to mid 1980s, I refer to this in my talks and in my memoir that I wrote last year as the dark days of my professional career, because at this point, we didn't even have a proper name for the disease, and we certainly didn't have an etiology. And essentially, all of my patients died for lack of any therapeutic intervention. And this is an example, back in the mid 1980s, the probability of death of a patient prior to the introduction of antiviral therapy was 51% in 1 year and 85% after 5 years. However, and fortunately, the advances in HIV/AIDS science over the now 44 years since the beginning of AIDS has led to breathtaking advances in treatment and prevention. Although the first drug was available in 1987 with AZT, in 1996 was the breakthrough year with the introduction of the protease inhibitors into a triple combination. We had a transformation of the treatment of HIV, shown dramatically on this slide, where the death rate very precipitously fell with the introduction of this therapy in 1996. And now, if you look today at the comparison between the 1980s, when I first took care of my first people with HIV, the duration of life, or the life expectancy following diagnosis, was about 1 year and at the most 2. Today, if a 21-year-old comes into clinic newly infected and you put them on HIV, you can predict they would live an additional 56 years, which in fact would make them almost a normal lifespan. Again, if you look today in the United States, and very similarly throughout the rest of the developed world, there are around 40 FDA-approved antivirals, including 13 single tablet regimens containing multiple drugs. This has led to a transformation in the HIV intervention, such that if you treat someone and get the level of virus to below detectable, they will not transmit the virus to anyone else, leading to the terminology undetectable equals untransmissible. In addition, pre-exposure prophylaxis with a single pill every day in an uninfected person, if done religiously and correctly, will prevent the acquisition of infection 99% of the time. We've done even better than that because now we have a twice yearly drug called lenacapavir, which is highly effective as an HIV PrEP and has been shown in 2 phase 3 trials to be 100% efficacious among women and adolescents and 96% efficacy among men and gender diverse people. This has now led to widespread approval of this preventive drug. There have been 3 regulatory approvals in the United States, the European Union, and South Africa, and 9 pending approvals at the end of October of 2025 in the countries shown on this slide. All right, let's move on now to something that is very much on the mind of individuals, and that is H5N1 bird flu, which, as shown on the date on this slide, did not start just last year. My first experience with bird flu was in 1997. We have known that chickens could get infected with a highly pathogenic flu for decades and decades. But in 1997, in Hong Kong, something different happened. The virus jumped to humans, and in this case, there were 18 human cases. But importantly, there were 6 deaths, which is very critical because regular seasonal influenza has a case fatality of less than a fraction of a percent. And even the pandemic flu of 1918 had a case fatality of 1 to 2%. This was a case fatality of 33%, getting the health authorities in Hong Kong to essentially cull all the chickens in Hong Kong, which led to a stopping of this outbreak for concern that it would develop the capability of going from person to person, which fortunately it did not. Now, the success of the Hong Kong authorities in killing all the chickens put an end to it for a few years. But in 2003 and 2006, again, it returned not only in Southeast Asia, but in other regions of the world. Again, 256 WHO confirmed cases and 151 deaths, which prompted the United States, and I was at NIH at the time, to develop a bird flu vaccine related to billions of dollars, which was invested by the Bush administration to prepare for a bird flu threat. We still have those vaccines in the stockpile that are somewhat similar in the sense of good cross-reactivity with the current strains of H5N1, but we really are thinking very carefully now about the possibility of making an even updated vaccine. The reason for that is shown on the present slide. Again, fast forward to 2024, 2025. Something different happened. That is, the virus inserted itself into dairy herds in the United States, over 1,000 herds in 18 states, in addition to the wild birds and other mammals. The fact that it's in mammals is concerning because that will allow itself to adapt itself possibly, and I underline possibly, to well transmitted from human to human, which has not happened yet, but it is of some concern. In fact, in the United States, there have been 70 human cases. There have been 2 fatalities. And again, fortunately, not yet, and hopefully never, going efficiently from human to human. Bird flu H5N1 is not confined to the United States. This is the WHO report, if you've seen in the small print, and I apologize for that, on the right-hand part of the slide, numerous countries since 1999 have reported a totality of more than 1,000 human infections with H5N1 bird flu. Let's move on to West Nile virus. Again, this is a classic prototypical example of a re-emerging infectious diseases. West Nile had never been in the United States, but was in Africa and the Middle East literally for centuries. In 1999, a plane took off from Tel Aviv to Kennedy Airport in the New York City area of Long Island. Now, either a mosquito, a bird, or a person on that flight wound up having West Nile, and then it began to spread throughout the United States through Culex mosquitoes. Fast forward now to today, West Nile is the leading cause of mosquito-borne disease in the continental United States, showing you the power of a re-emerging infection. Now, interestingly and importantly, about 80% of these cases are asymptomatic. 20% get febrile illness, and less than 1% get serious CNS disease. Now, in the United States in 2025, there have been 1,600 total cases and 1,100 neuroinvasive in 45 states and Washington. Now, this slide tells you that there were so many underreported cases, because if less than 1% are neuroinvasive, then we must be missing thousands and thousands of cases. Now, in the Washington, D.C. area, in 2024, there have been 4 cases reported. And as some of you may have heard, unfortunately, one of those cases was me. Now, if you look at the picture on the right, that's the neighborhood where I live in Northwest DC. And as I wrote in an opinion piece in the New York Times in October of 2024, I was infected in August. I literally almost died from a mosquito bite that I got in my backyard of my home in Northwest DC. Again, the threat of re-emerging infectious diseases. With regard to countermeasures, there's personal protective equipment and vector control. Unfortunately, we don't have a vaccine because our vaccine trials were limited because of the inconsistency of getting enough people with clinically irrelevant disease, because so many people are asymptomatically infected. Moving on to the first experience with SARS in 2003. Again, a new infection appearing in the Guangdong province of China, which was unrecognized and felt to be an unusual form of influenza until it went to Hong Kong and were infecting people at the Metropole Hotel who were infected in that hotel and then took off, as many people who are in Hong Kong do, and traveled to the rest of the world, leading to a global infection of 8,000 cases and about 780 deaths. Now, importantly, the transmissibility of this virus was very inefficient and was able to be ultimately controlled, as you've shown on this slide, peaking in April and essentially disappearing by June of that year. And the reason was that it was well contained by isolation of cases, infection control measures, quarantine, and school and hospital closures, travel advisories, and things like that. A very good example of public health control of a disease without a vaccine. Now, importantly, bats were ultimately shown to be the natural reservoir of SARS, where it went from a bat to a civet cat sold at a wet market in China that then led to the spread of this infection throughout the world. Moving on to Ebola, another example of a virus that likely existed for a long period of time, but was only recognized in Zaire, which is now the Democratic Republic of the Congo, in 1976. Importantly, the fatality rate is an average of 50% and may vary from 25 to 90% in past outbreaks. Again, another disease that originates from a zoonotic spillover from an animal reservoir, likely bats or other species such as non-human primates. Historically, there have been about 40 outbreaks since 1976, some as small as 1 to 10 cases, and as I'll show you in a moment, others with 10,000 or more cases. The two that I've had personal experience with is the outbreak in West Africa in 2014 to 16, with more than 28,000 cases and more than 11,000 deaths. A smaller outbreak in the Democratic Republic of Congo in 2018 to 2020 with 3,000 cases and over 2,000 deaths. But it keeps resurging, and the reason is the animal reservoir is always present. There's been an outbreak in 2025, January to April, in Uganda. That was the first outbreak there since 2020. And then most recently, just 2 months ago, an Ebola outbreak in the Democratic Republic of the Congo. Again, an example of how animal reservoirs continue to drive outbreaks. Now, I had some personal experience with this virus that I'll tell you about very briefly. In the United States, 3 centers were designated as capable of taking care of Ebola patients in an intensive care setting: Nebraska, Emory, and the NIH. As you probably know from the news, some of you may remember, a person from Liberia came to the United States infected and was hospitalized in Texas, and incidentally, because they didn't realize he had Ebola, infected 2 nurses who were in the intensive care unit. I had the privilege of taking care of one of these nurses, and here's a picture that actually went viral on social media and was on the front page of all the American newspapers, of my publicly discharging her by putting my arm around her in order to signal to the world that people who recover from Ebola should not be stigmatized. And we found out also that another patient I took care of, who was a person who got infected in Sierra Leone, that if you look at this, and I personally had the opportunity to take care of this patient. This is me as the infectious disease person together with an intensive care person getting ready to suit up and take care of a desperately ill United States healthcare worker who was infected in Sierra Leone and air evacuated to us. And this is me and my colleague taking care of this patient. I show it because in an intensive care way, if you can give people good intensive care, even the sickest of the people can actually survive. This young man survived and is alive and well to this day. Now let's move on to the most recent of these emerging infections, COVID-19. We all know it first appeared out of China in January of 2020, where China identified a new strain of coronavirus. If you look at the impact of this now, there is estimated between 7 to 35 million global deaths, around an average of 20 million. In the United States, it was 1.2 million individuals. I know Italy was particularly hard hit, particularly in northern Italy, one of the first of the non-Asian countries to experience the impact, the extraordinary impact of COVID. Right now, if you look at the deaths from COVID, which peaked in the United States, this is the global deaths early on in 2020 and 2021, which have now gone down to a baseline similar to the incidence as we see of influenza, except it's not seasonal. We're seeing COVID literally year-round. In the United States, the weekly deaths have dropped dramatically, though we did have a surge in it over the past summer. Now, The origins of this are disputed intensively now, of either it being a lab leak or a natural occurrence. I don't want to spend much time in this except to say that a large number of evolutionary virologists from Australia, Canada, the European Union, the UK have studied this carefully and feel, although we don't know definitively what the answer is, the fact is the scientific data strongly weigh to it being a natural outbreak and a spillover from the Wuhan market. But since we don't know definitively, we must keep an open mind as to what the origin is, although scientifically, the evidence strongly point to a natural occurrence. Now, with regard to vaccines, I want to spend just a moment saying something that I think is historic, that the vaccine development program led by the mRNA platform has done something unprecedented in the history of vaccinology. The viral sequence was released on January 12th. In the United States, my team at NIAID in the Vaccine Research Center, together with pharmaceutical companies, Moderna and Pfizer and others, within 5 days began the GMP production and preclinical evaluation of a vaccine. A phase 1 study began in 65 days, a phase 2 study in 139 days, a phase 3 study in 198 days, and in less than 11 months, a 30,000 person clinical trial showed both mRNA vaccines to be more than 90% effective and very safe. In fact, the effect of this, despite the misinformation and disinformation about these vaccines, has actually saved in the United States from December 2020 to November more than 3 million lives, averted more than 18 million hospitalizations, and saved more than $1 trillion in medical costs. The Lancet Infectious Diseases published a mathematical modeling study of the global impact of the first year of COVID-19 vaccination, that it prevented 14 million deaths in 185 countries from December 2020 to December 2021. And this estimate rose to about 20 million deaths when you used an excess death as an estimate of the true extent of the pandemic. Now, for their contribution in the development of this vaccine, as we all know, Katie Carrico and Drew Weissman won the Nobel Prize in Physiology or Medicine in 2023. I want to close by something that I think has really been an important factor, not only in the United States, but globally, is the misinformation and disinformation associated with not only COVID in general, but specifically with vaccines, that has led to a strong, unfortunate anti-vaccine feeling among certain segments of the population. This is a cartoon showing the 4 horsemen of the apocalypse meeting yet again another horseman of the apocalypse, that is misinformation. The consequences are severe. It has been estimated that in the United States, at least 232 deaths could have been prevented among unvaccinated adults in a 15-month period from May 2021 to September 2022, had they been vaccinated with at least a primary series, and they chose not to be vaccinated because of their concern about vaccines. Well, I want to end this particular discussion by the last paper that I wrote before I left the NIH in December of 2022. And that is saying it all. Namely, The title I gave it, it ain't over till it's over, but it's never over. Words emerging and re-emerging infectious diseases will be with us forever. They have been with our civilization since the beginning of the civilization. They're present now, and they will be in the future. And the only way to meet this perpetual challenge is to be perpetually prepared. Thank you very much.